is Antiana Talley. Today we have two wonderful presenters today. The first one will be presented by Nigeria Williams about gestational diabetes. The second presenter will be Kaylee Lynch, who is going to talk about ectopic pregnancy. I hope you will learn from these presentations. Enjoy.
How many of you, by a show of hands, have ever been pregnant? Now, keep your hands up if that pregnancy developed gestational diabetes. Quite a few of you have your hands still up, and that can be explained. Gestational diabetes, also known as GDB, is very common and resolves rather quickly. However, many women who develop GDM develop overt type 2 diabetes within 5 to 10 years after delivery. What places a mother at risk for GDM? Things like having a large infant, 9 pounds or more, also known as macrosomia, maternal age older than 25 years old, a maternal obesity greater than 198 pounds, previous unexplained stillbirth, or an infant having congenital abnormalities, history of GDM in previous pregnancies, familiar history of diabetes mellitus, and lastly, a fasting glucose more than 200 milligrams. Between 24 and 28 weeks, prenatal screening tests to identify GDM routinely performed. Some of you who have been pregnant may remember those insanely sweet drinks they made you swallow. It had a purpose. See, it was actually 50 grams of glucose solution. Some may fast, some may not, but it does increase sensitivity of the test. After an hour, a blood sample is taken. They analyze it for glucose. If they find that your blood glucose level is 130 to 140 milligrams or higher, a more complex, in-depth 3-hour glucose tolerance test is done. 2 abnormal 3-hour tests indicate GDM. Diabetes can affect the blood vessels that supply the placenta, impairing the transport of oxygen and nutrients to the fetus, and removal of fetal waste. That is why it is imperative that the mother is controlling blood glucose levels. If a mom enters a ketoacidotic state, it can be fatal to the fetus. So now you know what GDM is. You're probably thinking, so what? What can I do as a nurse to help the mom? One word: education. Diet and exercise are key to management. With dietary guidance and collaboration with a dietitian, you will counsel the mom that large meals with carbohydrates are not it. You are not eating for two. With therapeutic communication, of course. Balanced food intake and 3 or 4 snacks throughout the day to maintain blood glucose levels are ideal. You will also educate on exercise like walking, but in moderation. If she wasn't Usain Bolt before the pregnancy, now is not the time to try and be. Which brings me to my next point. Become the granny at church who always has some hard candy in her pocketbook. This is to prevent hypoglycemia after her walk. If GDM can not only be managed with diet and exercise, the physician may order an oral hypoglycemic drug like glyburide because it does not cross the placenta like metformin. After birth, like as soon as the placenta has left mama, she is instantly no longer suffering from GDM. And that is it. You have just cared for a mother with gestational diabetes. This was Nigeria Williams, and thank you for coming to my TED Talk.
Hi, my name is Kaylee Lynch, and today we're talking about ectopic pregnancy. So, what is ectopic pregnancy? Ectopic pregnancy is when a pregnant her fertilized eggs grows outside of the uterus into other areas like the fallopian tube. So when this happens, The fertilized eggs can't survive for a long time because of the decreased blood supply and sizing of the tube. This can cause it to die or cause the tube to rupture that results in bleeding into the abdominal cavity. If the fallopian tube can't be fixed, she can't have children anymore. The most common signs and symptoms of ectopic pregnancy is lower abdominal pain that is stabbing or sharp. Others include hypotension, tachypnea, vaginal bleeding, dizziness, weakness, and amenorrhea. If the fallopian tube ruptures, the signs and symptoms are fainting, shoulder pain, rectal pressure, and hypotension. So diagnosis for ectopic pregnancies are transvaginal examination, blood or urine pregnancy test, chodocentesis, which is the puncture of the upper posterior vaginal wall with removal of peritoneal fluids that shows bloods in the woman's pelvis that indicates the rupture. Laparoscopic examination with endoscope. Treatments includes blood transfusion for massive bleeding, methotrexate, which helps absorb pregnancy tissue and saves the fallopian tube, surgery to remove proof of cut conception, POC, if damage is small. Goals are to treat pain or nausea, make sure blood loss is replaced, and provide emotional support to the patient and family. Nursing interventions includes assessing the patient's blood pressure, heart rate, respirations, and temperature so the patient doesn't go into shock. Assess for dehydration, skin turgor, mucous membranes, cap refills, because blood loss and vomiting can cause hypovolemia. Make sure the patient is comfortable by lying flat and stabilizing the vitals. Assess abdominal pain, stabbing, sharp pain in the lower abdomen, which is signs of ectopic pregnancy. Monitor for blood loss and administer blood products. Prepare patient for surgery. Make sure their PO insert indwelling catheter. Maintain IV access and fluids. Educate the patient to prevent ectopic pregnancy, like not smoking and not having multiple sex partners. Evaluate the patient's pain levels, if they have decreased, and if hemoglobin and red blood cells are in the normal range. That's all for today. Thank you.